Hello, everyone. We are live. I'm waiting for a feedback in the comments to check if you can hear me well. Okay, thanks for the feedback, Gian Domenico. Good morning and hello to everyone. A big welcome to all the therapists around the world. We will wait 1 minute till anyone get connected. So for the ones who are already connected, I remind that you can write and type in the comments all the questions you have. At the end, we will take time to answer to as many as we can. Good morning, Anna. So 1 other minute of patience, then we can start. Okay, so a few more people get connected. I think that we can start. So again, welcome to everyone that is following us from all around the world. Today is the first appointment of a chat with FisioScience. There are going to be a series of live chat with different clinicians and experts of the fields talking about clinical practice and scientific research. Today, we are going to start. We have the honor and pleasure to have with us Jo Nijs. We're going to talk and have a discussion about motivational interviewing and pain neuroscience education. I will introduce him now. You're going to see live on the screen soon. Okay, you should be live, Jo. How are you?
I'm fine. How are you?
I'm good. I'm good. Thank you. Thanks for being here with us today. We really appreciate you to be here.
It's my pleasure. I look forward to it. You prepared some nice questions to discuss, so it's good. I look forward to it.
So, would you like to tell us a bit about who you are and what you do?
I'm trained as a physiotherapist and also as a manual therapist, and then I did clinical work, and then I did a PhD, and I'm now a professor at the University of Brussels, and also a visiting professor at the University of Gothenburg in Sweden. And the majority of my work is dedicated to the treatment of pain and improving the treatment of pain through our research and our education. And that includes people with low back pain, neck pain, post-cancer pain, osteoarthritis, etc.
Nice. So let's move forward to something that you have been studying a lot and you're using in your clinical practice. So my question is, what is pain neuroscience education?
Pain neuroscience education is a way of communicating to our patients, and it's explaining to them that pain is not that, or should not be that threatening as it is currently experienced by patients. And it's summarizing and summarizing the neuroscience, and not only the neuroscience, but in general the science behind pain and chronic pain in particular for our patients, and also of course delivering it and explaining it to our patients in a way that it's applicable to their situation, to their specific life situation, and it also becomes understandable to them. And this way we can improve the pain beliefs of our patients, and this is often a key aspect of the approach, the treatment approach for patients with chronic pain, because in many patients with chronic pain you see that there are maladaptive beliefs in the beginning, and pain neuroscience education is an effective approach of taking away those barriers for instance, initiating an exercise therapy program or doing any other active, or practicing any other active coping strategy. So pain neuroscience education is not a magic bullet, but at least it gives us an effective tool that can improve the pain beliefs of our patients, and this allows us to proceed in the next phases of the rehabilitation program, including exercise therapy, including stress management, sleep management, and whatever is needed for that particular patients. And to me also, pain neuroscience education is a really fun way of approaching patients and getting getting the confidence of our patients, because this way patients feel that they are understood by us as clinicians, and this generates and creates a therapeutic alliance with our patients. And therefore I think it's a really fun thing to do, and it creates a nice bond with our patients.
Thanks. There is also another strategy that you have been studied and it has been used in clinical practice. I'm talking about motivational interviewing. Can you tell us a bit about that?
Well, motivational interviewing is not so much an educational approach as compared to pain neuroscience education, but it's more a communication strategy. And a communication strategy that can be used throughout the treatment of patients with chronic pain or any other clinical condition, because the foundation, the origin of motivational interviewing is not in the field of chronic pain. It's more in the field of drug addiction, alcohol abuse. That's where the foundations of motivational interviewing lie. But there have been a series of studies also in the field of chronic pain showing that motivational interviewing can be a nice added value on top of other strategies. Of course, again, motivational interviewing is not a comprehensive treatment, but it's more a communication style. It's a way of approaching patients, which is often a bit contradictory to how many clinicians were trained back then. You know, I think it's more commonly integrated in universities and universities of applied science for training clinicians nowadays, but in previous well, people who had their education like 10 or 20 or 30 years ago. I don't think they were trained to communicate with the patients that way, because motivation interviewing is a much more empathic way of approaching patients, and less approaching patients in not so from an ivory tower perspective like we typically used to do back then, because in the old days it was like kind of the idea that the healthcare practitioners knew it all, and that they were available to provide appropriate advice and treatments to cure the patients. But nowadays, client-centered approaches are much more popular and gaining interest, and also because of trials showing that those client-centered approaches do better than more standardized approaches, and therefore motivational interviewing is an excellent way of improving your way of communicating with your patients.
Okay, I think you explained that very well, and you give us an introduction about pain neuroscience education and motivational interviewing. But what does the current literature say about that? What are the evidence?
Well, it's a bit similar for motivational interviewing and pain neuroscience education, in a way that nearly all trials are positive, positive in favor of these interventions. There are a small number of studies that, for instance, on pain neuroscience education, not showing any results, including one of our trials that we did in fibromyalgia patients, but that was like also exploring the dose that we need to provide to patients, because we, for instance, in the early beginning of our studies on pain neuroscience education, we did a successful trial in fibromyalgia patients where we tested whether providing 2 sessions of pain neuroscience education combined with an information leaflet was enough to change the patient's beliefs. And we showed in that study that was possible. And then we said, well, perhaps it's enough to just give the information leaflet. And that's what we tested. So just providing the information leaflet with all the content of the pain neuroscience education, combining it with 1 session of answering any questions and discussing the content very briefly. But that appeared to be insufficient. And also that single session was provided through telephone. So that study was negative in a way that it didn't show any positive effects of pain neuroscience education in people with fibromyalgia. But in that study, we showed that we as clinicians are really needed to provide pain neuroscience education in an effective way, and that we cannot rely on just sending them or providing them an information leaflet and then it's enough. No, it's clearly not enough. We need to actually engage with them in a one-on-one session, preferentially. Group sessions are also shown to be effective, but the effect size is smaller in those group sessions. But in general, when you combine all the trials that are available on pain neuroscience education in people with chronic pain, you get like small effect sizes. You get nearly always positive results, but you get rather small effects. Which is, to me, is not surprising, because in those meta-analysis, for instance, they looked at the isolated effect of pain neuroscience education. And for instance, we published a study 2 years ago in JAMA Neurology showing that there is a clear synergistic effect of pain neuroscience education and exercise therapy. And when you look at the results throughout the treatment approach, you only get small improvements in the educational phase. But then in the exercise therapy phase, you get the large improvements. But also only if the messages, the key messages of pain neuroscience education are continued in the exercise phase. And this can be done by providing cognition-targeted exercise therapy, so that you somehow translate the key messages of pain neuroscience education towards the real experiences during the exercise therapy. And this can be done by grading the exercise program independent of any pain flares, making them understand and letting the patients experience that they can do certain activities and exercises that they were previously scared to actually perform because they were anticipating that this would further damage their back or neck or whatever anatomical region that is painful to them. So if the exercise therapy is well aligned with the pain neuroscience education, like is typically done in cognition targeted exercise therapy, then you can have a nice synergistic effect, and then you can get medium to large effect sizes, and then you can clinically meaningful improvements in your patients, including on pain severity and quality of life. And so for clinicians, I would for sure advise them not to use pain neuroscience education as an isolated treatment, but combining it with other approaches, including exercise therapy, and make sure that other interventions are then well aligned in terms of the way you communicate with your patients during exercise and other interventions. And then you get the nice results, and then you get patients who are very happy with the treatment, not after providing a couple of sessions of pain neuroscience education. To me, when I approach a patient, not as a researcher, but as a clinician in the clinic, then to me the key goals of the couple of sessions of pain neuroscience education that I provide to that patients is making sure we create a common explanation for their pain that takes away the barriers for taking it to the next step. And taking it to the next step implies that the patient will be open-minded and will have a positive attitude towards a behavioral change, and will be motivated to invest time and energy in active coping strategies such as stress management skills, sleep management skills, and exercise therapy, or grading physical activity. So don't expect major pain decreases after pain neuroscience education. If you do get them, I think that will be very surprising, and perhaps then you should reflect on that patient a second time, because then there might be other explanations as well. So in the end, just make sure that the cognitions and the pain beliefs are improved after you have done your pain neuroscience education. And if not, just continue with providing education, and not in a real passive way, but do it in a more communicational style. You know, in general, we try to educate clinicians nowadays in a way that they provide pain neuroscience communication rather than pain neuroscience education. Because education in itself, it implies a real passive way of listening. The patient is listening to the clinician who has all the knowledge. And of course, if you do it in a communication style, then you start from the beliefs of the patient, and you always communicate with the patient, and you always ask questions to your patients. And that's where motivational interviewing comes in, because if you can do that in a motivational interviewing way of communicating with your patient. And therefore we advocate the combined use of pain neuroscience education with motivational interviewing, even though we don't have any trials showing that the two approaches can be combined and generate a synergistic effect, as we suspect and hope it does. Because the evidence, and that refers to the other part of your initial question, what's the evidence for motivational interviewing as an isolated treatment? It's very similar to pain neuroscience education. Nearly all trials are positive, but the effect sizes are rather small for chronic pain patients. But again, to me, that's not surprising, because motivational interviewing, similar to pain neuroscience education, is not a comprehensive treatment. It's not an isolated treatment either. It's a strategy that can be integrated into your comprehensive multimodal approach for chronic pain management. And the interesting thing about the studies on pain neuroscience education on the one hand and motivational interviewing on the other hand is that motivational interviewing has some different effects as compared to pain neuroscience education in terms of treatment adherence. Treatment compliance is something which is typically increased thanks to motivational interviewing. And I think that's a major plus. So that's why I think it's very appropriate to combine it with pain neuroscience education, because the typical small positive effects that you see in response to pain neuroscience education are a bit different, because they are more situated in the field of improving pain beliefs, improving pain cognitions, taking away those barriers for a more active approach. And so if you do that, if you provide pain neuroscience education to take away that barrier, and then in the next step that allows them to proceed with the other aspects of the multimodal treatment approach, including graded activity exercise therapy. But for those interventions, you typically require long-term treatment adherence from the patient, and that can be facilitated, supported, increased thanks to motivational interviewing. And that's, to me, is a key reason why we say to clinicians, well, try to combine both strategies if you have the skills.
So if I understood correctly, and tell me if I'm wrong, explaining pain to patients and getting them to understand pain is not lowering the level of pain itself. It's not that if you know pain, you don't feel pain, right? But it can change your behavior and your attitude towards a more active strategy that can improve the outcome of the exercise therapy, right?
Yeah, that's correct. Well, there are a couple of studies showing that you have some small positive effects on pain intensity itself, thanks to pain neuroscience education. But to me, that's not so important, because that cannot be the goal of pain neuroscience education. You will not educate the pain away. That's of course impossible, but you can change the pain beliefs. And because of changing the pain beliefs, you also can get some pain relief, especially in the long term, and especially when you let them apply a more active coping strategy thanks to the improved pain beliefs.
Okay, thank you. We have questions from Davide. I think you might be able to see it now. I'll try. Okay, can you read it?
Yeah, that's a good one. Thank you, Davide. Yeah, I agree. If so, the way you ask a question is somehow answering it already. So and I agree with your view. If the chronic pain patient has a predominantly nociceptive type of pain, and there are no psychological or social features that prevent an appropriate management of that particular patient, then it's possible that in isolated cases like this one, you don't have a clear indication for providing pain neuroscience education. So I agree that in general, and I think that's part of your question, that we should not advocate pain neuroscience education as a standard approach for all patients with chronic pain. And that's what I try to do as a clinician when I'm in the University Hospital of Brussels, working as a clinician myself. Then that's what I do when I see new patients for the first time. Then I explore whether pain neuroscience education is indicated or not. I have to say, of course, I work in a secondary care setting, sometimes even tertiary care setting, and then, of course, nearly all my patients, they have maladaptive beliefs. So we typically nearly always start with pain neuroscience education. There are a few cases that I recall that had appropriate beliefs when they entered our clinic, and that was very easy for us, because of course that allows us to start straight away with the exercise therapy program, for instance, or that we did stress management prior to the exercise therapy program. So in general, I fully agree with what you asked and proposed, Davide, that we should not use pain neuroscience education for all patients with chronic pain, but we need to have clear indications for providing it, and those indications are typically in the area of maladaptive beliefs, maladaptive coping strategies.
It comes up to my mind one other question, Jo. So before providing pain neuroscience education, should we ask permission to the patient to strengthening the therapeutic alliance?
Yeah, I think that's an excellent suggestion, and it fits well within the idea of combining motivational interviewing with pain neuroscience education. And because one of the key aspects in motivational interviewing is creating a therapeutic alliance, and you can do this by practicing shared decision making, and we do that a lot. You know, it's what you proposed is fully relevant for pain neuroscience education, but I think it's fully relevant for anything we provide and propose to clinicians. And I think the field of oncology is a bit ahead of other fields in the healthcare system in terms of when a particular patient receives the diagnosis of cancer, they typically have a number of treatment options to choose from. And typically then you have, for instance, one option with a 90% success rate of beating the cancer, but that option is often the most aggressive type of treatment, for instance, a combination of surgery and chemotherapy. And it implies that there is a fair chance of having some serious side effects from that treatment, which can impact on quality of life in the long term after the successful cancer treatment. And then often there is a less aggressive treatment, but then typically also the success rate of that treatment can be a bit lower. So then, of course, who's making the decision? Because it's a very important decision, obviously, because it's about the life of the patient. And then what they typically do in an oncology care is they explain the options, they explain the different options. They also provide the evidence-based medicine information in terms of with this, if you choose this option, you have a 90% success rate of surviving, but more side effects. And with this option, you have a 70% success rate for surviving your cancer and beating your cancer, but you will have less side effects. And then it's in the end, it's not the clinician or the oncologist who's making the decision, but it's the clinician informing the patient about the option, and then it's the patient who can decide together with their family members what will be the preferred treatment. And I think that's, of course, a very extreme example of shared decision making, where it's obviously indicated to not make the decision for the patient, but let the patient decide. But you can practice it in your practice as well, and this includes giving different options to patients after the initial evaluation phase. You know, after the intake, we typically provide treatment options for our patients, and we do this in a shared decision-making format. And in the beginning, the first time I did it, I was a bit anxious, similar to when I first started to provide pain neuroscience education to my patients. I was like, what am I doing? I'm teaching neurophysiology to my patients. That seems very strange. But then you get the first success experience, and then you become less anxious, and you're more confident. And it's the same with shared decision making. I wasn't trained as a clinician to provide shared decision making, but so I was anxious when I did it the first time. But then I saw the response of the patients, and there's a lot of science out there which is very strong in terms of its conclusions. If you include shared decision making in your treatment, you create a much more stronger therapeutic alliance with your patients. Patients like it. Don't be scared that patients will question your knowledge or your skills because you provide them options and you let them choose what the next step of the treatment will be. No, they really like it, and they feel acknowledged, they feel respected as an individual patient, not as and they really value the fact that they have the option to determine what will be the next stage. And I think this is very important for the treatment that we provide to our patients, because it's key to getting their motivation and making sure that they will engage in the program, because in the end, I'm trained as a manual therapist, but unfortunately our hands can do very little to get them back in control of their life and get them back to a normal quality of life. But they can do it themselves if they go along with the multimodal self-management approach, which is a common evidence-based approach now for treating chronic pain. So to get back to your initial question, yes, it's a lot of fun, and it's very supportive for our patients if you do shared decision making and provide options for them, and also for letting them choose: do you want explained pain, or do you want, or are you not interested in it? So let the patient decide, and also do it for any other phase of the treatment. I practiced it the other day with a patient who did well in the first pain neuroscience education phase, and then is progressing well also with the stress management part of the program, but will need to practice it further and integrate it further in life. But we also initiated, or had time in the session for initiating another aspect of the multimodal treatment, and we had options to choose from. Are you ready now to start the exercise therapy program or the graded activity program? Or the third option was, do you want to invest time now in improving your sleep? And the patient chose to invest time in sleep. And that's key, because the patient had the option to choose from. The patient made the decision herself, and is very motivated to first invest time in improving her sleep prior to initiating the exercise therapy program. And it's a lot of fun.
Thank you very much. We have a question that I also had in mind. You introduced before the combination of motivational interviewing and pain neuroscience education in our clinical practice. So Andrea is asking to you.
Yeah, it's a very good one. Andrea, it's obvious that you are well aware of what PNE is, and also you are well aware of what motivational interviewing is. And I know it doesn't seem obvious, because PNE is a more passive approach, providing knowledge to the patient, rather like contradictory to motivational interviewing, where you use open-ended questions and reflective listening, as you correctly pointed out. Well, and that's why we joined forces with several experts in the field from the Netherlands, including Rob Smeets, Paul van Wilge, Amarin Sveema, and also several experts from the United States, and including Adrian Law and Megan Donaldson, etc. And what we did all together, we created a script. We created a script that can facilitate the use of motivational interviewing and the integrated approach of motivational interviewing with pain neuroscience education. And that script provides you with a series of examples of how you can combine the two approaches, and also how you can adapt the approach towards the phase of behavioral change where the patient currently is. Because that's also a key aspect of motivational interviewing that I adore a lot, because it provides the option to provide an individually tailored approach to each patient, depending on the stage of behavioral change where the patient currently is. And we developed this script based on scripts that were available for approaching people with obesity to change their lifestyle, and then we adapted it to pain patients, and we adapted it to integrating pain neuroscience education into the concept of motivational interviewing. So we started from a script of motivational interviewing. And for instance, the open-ended questions, that's what can be used from the early beginning. You know, you don't start with pain neuroscience education. You don't need to start with lecturing straight away. You can start with open-ended questions like, what do you think is causing your chronic pain, and why do you think you still suffer from so much pain, in despite of the fact that the imaging results and all the test results are negative, and in spite of the fact that your physician told you that everything is fine in your cervical spine, for instance. So, and the script was important. Sorry, if I can add, perhaps the script is available in the paper. So we published a paper on it in physical therapy earlier this year, and it's included in the appendix. And there you have the script in English. And we have permission from Oxford's publishing journals. The publisher of Physical Therapy Journal provided us permission to translate the script in different languages. And we have now a script available in French, in Dutch, Spanish, Italian, and is it Greek? I'm not sure. Anyway, we have 5 different languages available on our website, the Pain in Motion website. If you go to the Pain in Motion website, www.paininmotion.be, and then you click to tools for clinicians. Tools for clinical practice, then you see all the different languages available, and then you get the option to freely access the script in the language that you prefer. There are a number of clinicians also working on I think it's a German version, so there are more versions coming up.
Thank you very much. I think it would be nice for everyone to go there and have a look at this simple and easy to use guide, because I read it too, and so I didn't find it in Italian, but now I know where to look. Moving forward with this topic, can you explain us the technique elicit, provide, elicit, and why it is important to provide PNE?
Yeah, I think it's important to also to engage them into the treatment. You know, if the patient is like when he first agreed to have pain neuroscience education as part of the treatment, then of course you don't use the words pain neuroscience education to your patient, but you tell them, if you ask them, are you happy to actually talk more about your pain and understand more about your pain, for instance, and if they respond positively, then you can start with it, and then you can elicit some intrinsic motivation. You know, you can elicit something by, for instance, challenging their beliefs. For instance, if they have real fixed biomedical beliefs in terms of, I think I'm quite sure, if the patient says, I'm quite sure that my neck pain is due to increased muscle tension, and there must be something wrong also in the cervical spine, and that's why my muscles always contract, and that gives me a lot of neck pain. If those kind of rather typical biomedical beliefs, if they pop up during a session, then we provide this approach by asking a question. You know, because if you tell them, no, that's rubbish, and it's all about increased sensitivity of the central nervous system, for instance, then they will not buy it for sure, because then you just provide another explanation for their pain. But why would they believe you? Because most of these patients have had so many different explanations before. So why would they believe you? So what we do, we challenge their beliefs, we challenge their cognitions by asking a question. And again, that's where motivational interviewing comes in very handy. And so you don't ask a question in a real real suggestive way. You just ask a question that makes them think, and that's what eliciting is all about. Let them think, let them reflect on their own beliefs. For instance, in that patient, that neck pain patient who thinks it's all in the cervical spine and then the tense neck muscles, we ask them, yeah, but then how come that you weren't successful with previous manual therapy treatment? Because I happen to know the manual therapist that used to provide you with treatment, and he's very good. He's an excellent therapist, much better in manual therapy than I am. So why do you think he wasn't successful in releasing your muscle tension and releasing and relieving you from your pain? So that's a question that can make them think twice and reflect on their own beliefs. And this is a total opposite approach than just telling them straight away that they should that they're wrong about their beliefs and that they should now adopt a new explanatory model. No, first make sure that they leave an opening in their reasoning and that they start to challenge their own beliefs, and that's when and as soon as they are willing to reconsider their own beliefs, then their mind becomes open for a potential new explanation.
Okay, thank you. We have a question from Davide again. I will try to show it up, but yes, okay, it works. A long one.
Yeah, that's very relevant as well, Davide. Of course, I will respond to your question. I first have a small comment. I wouldn't refer cognitive behavioral therapies or acceptance and commitment therapy as psychological techniques. I know you're right, and their origin is in clinical psychology, and those treatments are typically practiced by psychologists. But for instance, in terms of cognitive behavioral therapy for treatment of low back pain, we now have enough evidence. There is a systematic review out there showing that there is enough evidence to say that physiotherapists can, when they are specifically trained, they can provide cognitive behavioral therapy for patients with low back pain. We are currently doing the same in a large trial together with our colleagues from Ghent University. We're doing a large trial where we provide where we integrate cognitive behavioral therapy for insomnia into the education plus cognition targeted exercise therapy approach for people with chronic spinal pain. And there also we trained clinicians to provide cognitive behavioral therapy for insomnia. And when we look at the results of that trial right now, which is halfway the trial, we see that physiotherapists are able to practice cognitive behavioral therapy for insomnia. And I think this is in line with your question and your remarks. So where are the boundaries of our profession? I think it becomes more and more vague, and it's not only in terms of physiotherapy versus clinical psychology. I think it's for many other healthcare practitioners as well. Nurses practice pain neuroscience education or cognitive behavioral therapy, occupational therapists, etc. I know physicians who practice pain neuroscience education and take time to sit down with the patients and talk about their pain. So I think in general, the boundaries of the different disciplines within the healthcare system are becoming more and more vague, and I think that's very positive because it allows that we can focus the treatment and also perhaps 20 years from now, physiotherapists were only focusing on exercise therapy for chronic pain management, while psychologists were practicing CBT. And nowadays, I think psychologists learned that exercise therapy is a very useful add to, or can be an integrated part of CBT. And we as physios, we've learned that we can practice many of the CBT skills and to make our exercise therapy much more effective. So I think it's very positive for healthcare, for chronic pain management in general, that the boundaries are becoming more and more vague, and also it's surely benefiting our patients. It's not that they should choose, well, where do I go? Do I need to see a physio or a psychologist? Well, let's hope they get a real similar treatment, or at least in the similar with the similar reasoning behind it, the similar rationale of the treatment. If they get different treatments but with the same treatment principles, then they can only get can benefit from it.
Okay, good.
But
so
if I can add one thing, because the final sentence of that question was, when should we send patients to a psychologist? Well, that's also a very important one, because of course that's what we need to do during the intake, when there is a clear psychiatric morbidity or comorbidity. For instance, when they have a real severe active depression, then of course we typically refer them to a psychologist or psychiatrist first, and that we, unless they are already being treated by a psychiatrist or a psychologist. So that's really important, because we also know that exercise therapy for chronic pain and CBT provided by psychologists will not work. CBT provided by us physiotherapists will not work if the patient has severe psychiatric comorbidities, like a real active anxiety disorder, for instance, also should be treated first by a psychologist or psychiatrist.
Okay, thanks. So I have one more question for you. We said before that motivational interviewing and pain neuroscience education are both two useful strategy in the management of chronic pain, but they surely are not enough in order to have a successful management of the chronic pain. So a modern clinician, what other kind of strategies and treatment choice should employ?
Yeah, that's a very important one. I think we partly already mentioned it before, but other aspects that needs to be covered in a multimodal approach for people with chronic pain typically include stress management, sleep management, graded activity, or any other approach that allows them to return to more daily activities, including social activities, including physical activities, household activities, etc. Graded exposure can be very useful. Behavioral graded exposure can be very useful, especially to address the activities that are really threatening to the patient. So with where they present a phobia, to actually return those activities. Other interventions that can be useful depending on the individual patient includes nutritional interventions, optimizing their nutritional intake, optimizing their diet, especially when patients are overweighted or have a poor diet. Then, for instance, in osteoarthritis patients, we know that patients with osteoarthritis who have overweight, that providing a weight reduction program, including a dietary intervention, has an added value on top of education and exercise therapy. So that's also something to consider. But it's not that we should combine all those approaches in each individual patient. It's more being selective, and when a patient comes to our clinic and I see him or her for the first time, we do a thorough intake, and then I tick the boxes, then in terms of, I think for this patient, my assessment is that stress management plus sleep management plus exercise therapy is indicated. But then that's my assessment, and then I explain this to the patient, but I also provide options to the patients again. And for instance, that patient that according to my judgments, requires sleep management plus stress management plus exercise therapy, that patient might come to me and ask me, well, yeah, I want you to use your hands and provide me with hands-on manual therapy for treating my low back. And then that would be one option that I propose to the patient. And of course, when I have made my judgments, then I provide the option that I would prefer. And then the other option, which is in line with the patient's expectations. And if the patient has the expectation for receiving hands-on manual therapy, so pure passive treatment, and I am keen to provide the more active approach, then it will not work if we impose it upon the patient. So I let the patient decide using the shared decision making that we previously discussed. But referring to hands-on manual therapy, that can be part of the treatment as well, but then there has to be clear indications and make sure that it's not the main component of your multimodal approach of individual patients, and make sure that if you provide hands-on manual therapy, that you always combine it with education, exercise therapy, and stress management interventions that allow the patient to focus in the treatment of teaching active ways of coping with their problem rather than relying on your magic hands. Because I don't know about you, but I don't have magic hands, unfortunately.
Yeah, me neither. Me neither. Yes, Davide had questions about manual therapy, but you already answered about that. He was asking if it was if manual therapy can be a valid ally to PNE and motivational interviewing in the treatment of persistent pain. But you already said that it's important that if you decide in your clinical reasoning to provide manual therapy, you must educate the patient and also lead him to a more active coping strategy. So
exactly.
we will check 1 minute, few minutes if there are any other questions. Well, we have a question from Simons. So he's asking, do you assess for maladaptive beliefs in a standardized way?
Yeah, we do, but of course we are in a setting where we only see chronic pain patients. So we have a standard set of questionnaires that we send to them prior to the first meeting, and I ask them to complete those questionnaires and have them filled out and hand them over to me when I first see them. And of course, when you're working in a setting where you treat a variety of patients, and you first need to make sure that they are actually coming to you for chronic pain management, and then you can provide them with a set of questionnaires, I think, on beforehand, and that saves time in the clinic. And of course, make sure that the set of questionnaires is not too long. And I always try to identify questionnaires, one-page questionnaires, for instance, that are easily filled out by the patient. And I also delete what's on top of the questionnaire, you know, the upper line of the questionnaire, because one of those questionnaires that I use is the pain catastrophizing scale. But if the patient sees a questionnaire and on top of it, it says pain catastrophizing scale, even before he ever met me as a clinician, then it's even possible that he will cancel the first appointment. So I would not let that on top of the questionnaire. So delete that, and then it's a very useful tool. You know, the catastrophizing scale. It generates 3 subscale scores: rumination, magnification, and what is the third one? Worrying, I think. No, that's the rumination. Anyway, it's a very useful tool, and it generates some clear indications whether or not pain neuroscience education is indicated, because decreasing catastrophic thinking is one of the typical observations done in clinical trials when you look at the effects of pain neuroscience education. Other questions, information about the pain cognitions and about the beliefs of your patient, and this is something that I typically also use to further guide my questioning during the history taking. You know, then I further ask the patients to let me explain how the questionnaires that we use is the questionnaire that assesses the inability of the patients to actually cope well with their pain and accept their pain. You know, it's the questionnaire that that assesses the construct of perceived injustice, and we see it in about 1 out of 4 patients that there is some aspect of perceived injustice, and that implies that patients do not accept their pain condition, and that they are fighting against their pain problem, and that they are sometimes angry or frustrated with, for instance, an orthopedic surgeon who, according to their views, has actually done something wrong during surgery and triggered the long-term post-surgical pain, for instance. So that's very useful as well. I also typically use the CSI, the Central Sensitization Inventory. It's a 1-page questionnaire that assesses symptoms that are supposed to reflect increased sensitivity of the central nervous system. So that's, to me, is also a useful tool. But in the end, it's not only the questionnaires; it's making sure that you don't rely only on the scores of the questionnaire, but also rely on what you assess during history taking with your patients.
Of course. We have last questions from Davide. He says last questions. He is interacting a lot today. So you should see it now.
Yeah, also very good one. Yeah, and I think that's one of the misunderstandings that are around there, that pain neuroscience education is a synonym for explaining central sensitization to your patients. And the question in itself is very useful for other clinicians listening, because it often happens that a chronic pain patient doesn't present a clear picture of central sensitization. As Davide correctly pointed out, many patients with low back pain do not have clear clinical picture that gives us evidence that central sensitization is dominating the clinical picture. And in those patients, it can be totally wrong if we then use central sensitization as the explanatory model for that particular patient, because those patients will probably not recognize themselves in a story that uses central sensitization as the underlying idea. But then, of course, in that patient and in nearly every chronic pain patient, you can always use the pain matrix to explain their pain. You know, if you are familiar with pain neuroscience education, then you are trained to actually explain about the descending action orchestrated by the brain, and which is then influencing what is happening at the level of the spinal cord, and particularly in the dorsal horn. And we often use the spam filter metaphor to explain that. But when we explain to our patients what is happening at the level of the brain, when the input, the sensory input, is processed in the pain matrix, that part can always be used to any patients, because it's not specific for patients with central sensitization. It's applicable to any patient with chronic pain, and even it's applicable to acute pain experience, because it implies that the brain is processing the sensory input and is also then processing it in a way that it takes many other issues into account, including the context, including previous experiences, and therefore that part of explained pain is useful to any patient with chronic pain. And so in conclusion, I'm totally in support of your question, Davide, and make sure that you do not explain increased sensitivity of the central nervous system to patients who don't have clear clinical signs of central sensitization, because they may not recognize them into the story, and this can then decrease the therapeutic alliance rather than increasing the therapeutic alliance.
Thanks really much for the explanation. We have one other question from Andrea.
Yeah, sure. Very good one, Andrea. That's possible because manual therapy provided in the old-fashioned way as a real passive approach, manual therapy in strict sense, if you want to call it that way, that can conflict with messages provided in more other approaches like PNE, CBT, ACT, and exercise therapy. I fully agree. But of course, it's possible to integrate them if you think it's indicated. For instance, in people with osteoarthritis, I think with hip osteoarthritis, for instance, there is evidence that manual therapy has an added value, small added value, that is on top of exercise therapy approaches. And if you want to combine them, then I think you can do that, but then you have to make sure that you provide PNE first. So explain pain to them first, make sure that the patient changes their beliefs prior to you providing hands-on manual therapy. And also change the way you communicate during manual therapy. And make sure that you align your communication during your hands-on treatment with the messages provided during PNE. And this implies that you will not communicate in the old-fashioned way, like tell me immediately if my technique is triggering more pain, because then I will adapt the technique, because that's the old-fashioned way, how I was initially trained as a manual therapist. And then, of course, you rely on pain and you increase the threatening nature of pain. And that's totally not done with our current understanding of chronic pain. So on the contrary, what you do is then you use a metaphor that you use in pain neuroscience education to also approach the patient for your hands-on treatment. For instance, I often use the metaphor of the spam filter. And then I tell them, okay, I will now start. I will use my hands and I will touch your lower back, for instance, and this way I will do this to activate the spam filter in your which is orchestrated by your brain. So I will use my hands to activate your spam filter. And if you used, for instance, another metaphor like the sensitive burglar alarm, then I will tell the patients I will now use my hands to decrease the sensitivity of the burglar alarm in your nervous system, rather than telling them that I will use my hands to fix something in the lower back. So that's another way of communicating with hands-on manual therapy, and this somehow makes sure that we do not conflict with key messages provided in the more cognitive approaches of the treatment.
Thank you very much for the explanation, Jo. We are running out of time. We are at the end of our chat. I hope you have enjoyed your time here with us. We had many questions, many good ones, that you have really explained everything to us again and again. So thanks, a big thanks from the team of FisioScience International and to everyone that has followed us today from all over around the world. So big thanks again.
Thank you for organizing everything, and thanks to everyone listening and for the wonderful questions we had. And we have to say that those who were not asking questions, we didn't pay the people for asking these questions. They actually asked them themselves. At least unless you approached them beforehand, because they were really good questions.
I cannot say that, but we have been studying in the last few days. I just want to remind to everyone that you can see this live chat again in our YouTube channel, in our Facebook channel. So if we stay there, if you have missed that, don't worry, you can see it again. Hello to everyone. Bye-bye. Have a nice day.
Bye.